Well, hello once again, and it's always a great pleasure to be able to share things, especially things that are dear and passionate to you, as this topic is for me. And I hope you get something out of this as well. As a quick aside, for Roman's sake, I'm wearing my Metallica t-shirt. Roman and I share a lot of things in common, but one of which is our predilection to enjoy heavy metal music. So anyway, rock on, Roman, and hope you heard some good music lately. So I mentioned passion, and that's very important to get us out of bed every morning. And one of the things that I've always been interested in is ways of becoming targeted in our therapy, or what we call local regional therapy, targeted therapies. I think those are extremely interesting modalities for us to explore. So I'm going to share with you a little bit of my experience with intra-arterial chemotherapy strategies for salvage therapies of intractable brain tumors. And these are techniques that are trying to marry endovascular techniques with other types of treatment strategies. So my first image is that of Yoda, of course, from Star Wars, and Yoda being sage and wise and someone here to counsel us. And I put this up here simply because it tells us that we always need to remember our roots, and especially to remember and revere our mentors. So two of my mentors are pictured here. On the left is Charles Kerber, and on the right is Wade Wong. Chuck and Wade were extremely influential to me as a developing surgeon, as a neophyte resident, and they continue to be a huge part of my life. And I'm very grateful for that. And both are not only exceptional neuroradiologists and physicians, but exceptional human beings and teachers and educators. And I hope someday some of you may have a chance to meet some of these exceptional people. But I also mentioned Chuck and Wade in the context of this talk because they really spearheaded the whole intra-arterial chemotherapy approach for head and neck cancers in the 1980s, which when I was a fellow in the 1990s was a real impetus for me to think about this. So they started in about 1985, 1986 with one other colleague, an oncologist named Robbins, to use intra-arterial chemotherapy for squamous cell cancers of the head and neck, for instance, tongue. Patients with a tongue squamous cell, tonsillar squamous cell, faced really grim options because a glossectomy would mean you could no longer speak and probably wouldn't be able to eat, probably needed a PEG tube for eating, and obviously extremely unpleasant to think about. And especially patients who had a recurrence, they then now had a hostile surgical environment. So they came up with this technique, which was incredibly successful even to this day. One of the major aspects of intra-arterial chemotherapy is that the dose that gets inside of the tumor of chemotherapy is anywhere from 80 to 200 times whatever you could push IV. And that isn't just limited by toxicity of an IV route, but also just the sheer physics of trying to get that degree of bolus into a tumor. The other interesting thing is depending on what you choose to use can have huge influences on the patient's body exposure and complication and side effect profile. So if you use cisplatin, you can also give, while simultaneously the intra-arterial cisplatin, a simultaneous rapid infusion bolus of sodium thiosulfate. And what that will do is act as a chelating or neutralizing agent for the cisplatin. So the cisplatin bolus starts in the arterial side, hits the tumor, huge amount, goes into the venous circulation. But as soon as it's into the venous circulation, it is chelated and inactivated. And that, therefore, is organ sparing. So it's a beautiful local regional technique to use. And the patients don't get marrow suppression and renal and hepatic dysfunction, et cetera. So here's the first case I want to share with you. This is a 67-year-old female. She had a right parotid neoplasm diagnosed in 2008. That was a sarcomatoid type of lesion, and the lesion was completely resected, and she received local radiation. And then in 2012, she had a new lesion in that same ear, pinna area. This turned out to be an atypical fibroxanthoma, a form of dermal sarcoma. You can see it there. And then this was biopsied shortly thereafter. And then she had IV chemotherapy. This was a malignant spindle cell neoplasm, once again, a sarcomatoid carcinoma, some sort of sarcoma family. In December 2013, despite systemic chemotherapy, she's now had continued progression of this lesion. And by January 2014, it has continued to progress, and now you can see there's a great deal of not only necrosis, but intratumoral hemorrhage. So it's a highly vascular tumor. She then presented at my hospital in March of 2014 with this incredibly bulky continued growth of this lesion. This had totally upset people in the ER and the ICU. People were worried that this was to become a carotid blowout and would be fatal immediately. It also was infested with maggots and flies at this time. And here is a lateral view. So you can see this is an incredibly bulky tumor, highly vascular. So ultimately they consulted me and asked for my opinion, and I gave them a plan. So here's our MR imaging preoperatively, and you can see not only is this obviously extracranial, but it's intracranial and goes totally across the temporal bone as well as into the epidural space, and even started to invade brain parenchyma. So here's some coronal views. Once again, you can see the extensive involvement of multiple layers of the patient's head and neck and intracranial compartment. So what are strategies in a case like this? You know, I think you really have to be well defined when you talk about your goals. And obviously you have to have safety as a major part of the discussion as well. And you have to have a well-defined endpoint. So my goals in this case were to palliate this patient. In other words, to keep her comfortable and allow her, however, to have some degree of social acceptability and social interactivity while keeping her as safe as possible. Realizing from an endpoint discussion, I cannot cure this, but maybe I can control it. And at the time, this also, just to complicate matters further, had a polymicrobial bacterial infection with Citrobacter, Cosaria, and Staph aureus, and then the maggots as well. So my plan was first to do a transcatheter embolization to devascularize this, to make it safer and easier to resect. And then another strategy I want to share with you is what's called direct puncture embolization. And I use ethanol, 100% ethanol, absolute alcohol, vodka, basically, for this. And this is a very nice technique. It's simple, it's quick, and it's inexpensive. And anybody can do it. You don't have to be an endovascular trained neurosurgeon in order to do a direct puncture technique. And it's always something to keep in the back of your mind. Great trick, and I'll share that with you in a minute. Then I was going to move to debulking of the extracranial extradural massive component, clean that up, allow her to recover, and then do intra-arterial chemotherapy. So flood that whole region and then do an intradural debulking. And certainly my plan isn't the only plan that could be used, but I had my rationale for doing it this way. So this is a right external carotid run, and you can see there's some faint blush in and around the area where the tumor is. So this is what I used for my initial embolization, which was particle polyvinyl alcohol, like we discussed at the middle meningeal artery embolization talk. This is what's called a roadmap view. This is an AP view, anterior posterior view, but you can see there's a fair amount of vascularity in that tumor, and it's important to understand these and scrutinize them to look at the venous drainage so you know where things are going to be draining to. This is an unsubtracted view with a microcatheter to the middle meningeal artery. So I've done a super selective angiogram in the middle meningeal artery. You can see the typical appearance of the MMA, which is feeding this, and that was my treatment point with the particles. So this is direct puncture, what I was talking about earlier. So what I've done here is taken a 22 gauge spinal needle, and I've directly put that into the mass that is protruding from the side of her head. And you do this under general anesthesia because the ethanol is obviously going to sclerose immediately, and it'll be very painful to any nerves in that area. But here's the caveat. Here's what you need to understand about using ethanol. Ethanol is not radio opaque, so you cannot see it after you inject it. It's just going to travel based on the physics of the region. So you have to do something in order to get a feel so you can estimate where the ethanol is going to go. So I do a test run. In other words, I put my needle into the treatment position. Then I take a syringe that is exactly the same in its construction and volume, size, etc., that I'm going to use to inject the ethanol. But instead of ethanol, I'm going to inject contrast or dye. And I'm going to look at how the contrast is injecting, and I'm going to figure out just how much tactile pressure I need to optimally flood the area without over pressurizing the system, which will then potentially cause ethanol, when I use the ethanol, to go to places I don't want it to go. And you have to scrutinize this once again to be sure you're not draining into areas that perhaps the facial nerve or the hypoglossal nerve, or that may have some sort of anastomosis with intracranial circulation. So once you're confident after your contrast injections with the field, then you move to your direct puncture ethanol syringe. Don't move your needle position at all. After you've done your contrast runs, just keep your needle there, throw your contrast away, and screw on your ethanol syringe, and then inject in exactly the same way. You will start to see the effect immediately. You will start to see the tissue blanch and start to firm up and even shrink. So this is just minutes after I've embolized with direct puncture ethanol this lesion. You can see the droplets of blood, very bright arterial blood, is how vascular this lesion was, and that's where my needles were. But also, this is also immediately starting to undergo change, and it's starting to basically become like a wooden projection. And it was a very simple matter to resect that using sharp dissection. And that's post-op day number 2. At this point of her life, she already developed a facial nerve palsy. But you can see, it was very simple, and otherwise the rest of her skin looks fine, and she doesn't have any necrosis. And she was discharged on the second day directly to home and was able to enjoy her family. So here's her post-operative MRI. Obviously, we still have all of the intracranial component and the component that was inside of the skull and in the masseter. Inside the masticator space and infratemporal fossa. So as I said, these are the areas that IA chemo, is now designed to try to clean up because obviously you're going to have an incredible time to try to take out tumor that is in the infratemporal fossa and pterygoid plate, etc. But now, as I've said, the IA chemo approach, this is what makes sense to me to do at this time, to try to now spray that whole area. So once again, I use this cisplatin sodium thiosulfate inactivation trick for her. And as I've said, this is a targeted therapy, and that's the beauty of local regional targeted therapy. So if you understand what your target is, if you understand how to get to your target, you will then be able to affect some positive change. And this is a great target. This is quite a fat bear. For those of you who aren't aware, Katmai National Park in Alaska, right across the Bering Strait from, of course, Siberia, has a contest every year as to which bear is the fattest Okay, so this is the fat bear contest, and people are supposed to spot the bears, take their pictures, and submit them. And this was one of the definite contenders for the Fat Bear Week contest at Katmai National Park. So here's my treatment position. This is my second intra-arterial chemotherapy cycle. This is 4 weeks after the surgery. So generally about every 2 weeks, I'll do the IA chemo. One of the issues with IA chemo patients, as you treat them further and further, and as you become more successful in treating them, the vessels do undergo changes. So they're not just neoplastic changes, like the corkscrew type changes you'll see and the proliferation, but you also start to see a lot of irregularities. And here you can see that in some of these external carotid artery branches. And that's often a sign that your treatment is working. So here is 4 weeks post-operatively prior to her second intra-arterial chemotherapy. Patient looks much better, she feels much better, no pain, and we are having at least some degree of control of that tumor. Unfortunately, she developed pulmonary metastases. As I said, no one was ever under the illusion that this sarcoma would be cured. She survived for about 4 months after her last IA chemo dose, but I have to say, most of that time was spent at home, so I think there was a small victory here. Second case is that of a 56-year-old female who was my patient. I met when she was 46, and I resected a left frontal lobe oligoastrocytoma, and she had chemotherapy and radiation therapy. About 4 years later, she developed renal cell carcinoma, but it was not metastatic to the brain. It was localized and was successfully treated for that. Then when she was about 6 years after that, she developed seizures. And it was noticed by her neurologist that there was a mass, a cutaneous mass in the left frontal scalp along that old incision line from all those years ago. So you can see my incision line in the center, and then you can see this mass that has a purplish cast to it and multiple lumps. So obviously the concern was that this is some sort of neoplasm, potentially even a sarcoma, perhaps induced by radiation. So the mass extended into underlying bone in the epidural space. So I did a widespread excision of the scalp, bone, and dura, and this turned out to be an aggressive meningioma. Once again, probably radiation induced, WHO grade 3. Within 3 months of that surgery, the mass rapidly returned and continued to grow. So here you can see on our MRI, 3-month post-op, you see the epidural space has this mass that's also into the subcutaneous tissues. And here's what it looks like here. So I decided to first start to treat this with cisplatin IA chemotherapy as one other method of treating this, because I'm kind of stuck in this situation because I can't just keep resecting more and more of her scalp, because there's already a large scalp defect here that's subsumed by tumor, but eventually you have to draw a line somewhere. So this is after 4 cycles of intra-arterial chemotherapy, and that was given over approximately 6-week, 7-week period of time. And you can see these are very typical changes of a successful IA chemo strategy. The tumor starts to mummify and starts to undergo basically dry gangrene, which is exactly what we want. And then it simply is ready to fall off on its own. And some of my patients I've treated with IA chemo have had neck cancers, bulky tumors like this, literally will call me the day it falls off at home onto the floor. Hopefully the dog doesn't eat it, but that did happen to me once to one of my patients. But the idea, once again, is that it can come off without even you ever touching it with a scalpel. So my approach here was a repeat wide excision and a craniectomy. And this time, just to mix things up further, I did a different twist on local regional therapy and used what's called Glyadell Carmustine chemotherapy wafers. For those of you who are not familiar with this, this is a commercial product. It is polyfoprosan, which is a polymer wafer that has carmustine in it, BCNU. Basically what this does is leaches out the chemotherapy from the wafer for approximately 8 millimeters to 10 millimeters away. And then this process goes on for 3 weeks. That's how it's been formulated. And then the wafer biodegrades. So it's indicated in the United States for glioblastoma and anaplastic astrocytoma, both up front during first resection as well as for recurrence. And you basically line the resection bed with these. And it has increased survival by about 5 weeks to 6 weeks median. So this is 3 weeks after her craniectomy, IA chemo, and Glyadell chemotherapy. You can see 2 of those wafers underneath that lower bar there. She obviously does have a scalp defect now because that really was no longer skin. It was all tumor, so I had to take it. So here's 4 months after that procedure. And at that time, she had a negative biopsy. So I felt that things were going well, but she did have a small recurrence at that time for an atypical meningioma yet again. And then within 3 months, she's had a rapid filling in of that entire scalp defect, but still remains neurologically intact. But you can see from this MRI, she has significant tumor regrowth once again. And that's what the tumor looks like grossly before resection. So I did a repeat craniectomy with this time noticing that the tumor extended through the titanium mesh I'd even put there. So that didn't even fence it in. It literally goes through the mesh into the epidural space. It was easy to curette it off of the dura, and the path once again was positive for a grade 3 meningioma. The problems I've been facing with her is what to do with this scalp defect, which is approximately 6 centimeters by 7 centimeters. My latest approach and trick to using this is to cover the whole area with what's called a HemoShield graft. This is an aortic synthetic graft intended for use in the aorta, but I just simply cut the tube to make a patch graft out of this and suture it on with Proline. And this will last for about 5 to 6 weeks before basically we get bacterial superinfection and colonization. And then it's very simple to take this off, debride, clean the area out, and cover it again with this. The hope here is that this will all heal by secondary intention, and it is starting to finally granulate in. My only concern here is whether or not the tumor grows back again. I'm kind of going to have to return back to ground zero because I'll have to resect more of this grown-in material. So this saga continues. The patient is doing well overall, but once again, it's a very tricky business for me anyway. So what are future directions of intra-arterial chemotherapy? In other words, how do we move beyond things like cisplatin or gemcitabine? You know, some of the most common IA chemotherapy, traditional chemotherapy drugs. Well, certainly genomic modifiers are very, very exciting, and that's an extremely exciting field with antisense DNA and being able to use CRISPR technology. This should hopefully give us something different to use. So we have tools and techniques to drive ourselves, i.e. drive a microcatheter into a tumor's doorstep. So we just have to become smarter now and figure out what do we want to deliver through that microcatheter. So we drove there. What do we want to do once we got there? And that's where I think we really need to make alliances with our pharmacology and molecular biology colleagues and try to figure out what type of things we want to deliver through microcatheters into tumors. And I leave you with the tale of Spark Therapeutics. Spark Therapeutics is a US company that focused on actual genetic modification of disease states. So their first focus is a single allelic mutation that occurs in some children that changes the retinal cells so they die off. So basically the patients all become universally blind by about the age of 9 or 10. It's a retinal-based blindness. So they developed a method which is basically a single intraocular injection of this drug, which actually repairs the genetic defect in the retinal cells, the resident retinal cells of that patient. The drug's called Luxturna. It has created a lot of controversy in the United States because the single dose injection has been priced at $1 million. So there's been great discussions as to why does it cost so much? It's unethical to do that versus how much would you pay if you knew your child was on this path of blindness for certainty? How much would you pay and how much is it worth to preserve a child's vision and return them back to normal? Obviously, the debate is ongoing, excuse me. Roche actually acquired Luxturna and Spark Therapeutics for about $4.3 billion in M&A deal about a year ago. But I don't mention it because of the finance point of view, but I mention it because of the ability to do it and the fact that maybe someday we're going to be able to figure out how to change epidermal growth factor genes in glioblastomas, or whatever gene it is that is in this meningioma that my patient has, or that sarcoma that I showed you. So once again, I thank you very much for this kind invitation, and it's been a real thrill to be able to share with you some of my passions in neurosurgery. I never thought I would have answers for you for these difficult cases like what I've shown you today, but I hope we do stir some questions up and maybe some new horizons will appear. And maybe one day we can all work together on this. Thank you again. See you next year, hopefully.